I'm Dr. Cassi from Vetfolio and the host of Vet2Vet. Osteoarthritis is commonly diagnosed in small animal practice. We see it most often in older or overweight patients, and helping these patients and their owners with a treatment plan that works and works for them is key. Today we're discussing the multimodal approach to caring for our osteoarthritic patients with Drs. Chris Frye and John Loftus. Dr. Frye is a diplomate of the American College of Veterinary Sports Medicine and Rehabilitation. He's an assistant clinical professor of sports medicine and rehabilitation at Cornell University. Dr. Loftus is a board-certified small animal internal medicine specialist and boarded nutritionist. Dr. Loftus' general research interests include immunology and nutritionally responsive diseases. So, Dr. Frye, Dr. Loftus, thank you so much for joining me today.
Thanks for having us.
Delighted to be here.
Yes, and I'm delighted to have you guys on the Vet2Vet episode. Let's jump straight in. When it comes to management of any chronic condition, arthritis of course included, I feel like the old saying, which I find myself using so much in practice, that an ounce of prevention is worth a pound of cure, really applies. So would you agree, Dr. Loftus, what kind of actions can we take to help prevent arthritis in our pets?
Yeah, so I think it really starts early. And one of the themes that I often talk about, especially with nutrition, is starting off early as puppies and setting the stage for healthy adulthood. And there's really kind of two components to that. One, I think, is just having a good quality diet. And then also feeding the right amount of a good quality diet. And that's where I think a lot of our clients go a little bit wrong. We know there's really good studies showing that dogs that ate fewer calories throughout their life had lower incidence of osteoarthritis and several other diseases too. So we'll talk a little bit more about weight management as we go along here, I think. But in terms of prevention, I think that's one of the key things. And then treating arthritis really gets into nutrition and other medical management. So we tend to think there are several nutritional characteristics that can help reduce inflammation. We want to maintain our patients as lean as we can and optimal body condition, because that's going to reduce, may not necessarily reduce arthritis itself, the incidence of arthritis, but it certainly will mitigate some of those effects and make them more mobile throughout their life. When they do develop osteoarthritis, there are nutritional supplements that may or may not be in food. So some food comes with added supplements like glucosamine or omega-3 fatty acids that are beneficial. And then if not, then we can supplement those. As most vets know, there are plenty of nutritional supplements that they probably have on their counters in the vet clinic. And then after that, we start to get into pain management and physiotherapy or physical rehabilitation, which Dr. Frye is an expert in, of course.
Yes, and really, gosh, with that just that brief nutritional synopsis, I feel like I have so many follow-up questions. Like you said, dogs that ate fewer calories throughout their lives and maintained in a lean body condition, does that mean that they tend to do better if they stay lean throughout their life rather than if they were heavy and then they lose the weight?
Yeah, so this was really a study that looked pretty much over their lifespan. So there were two groups of dogs. I think they were all Labradors, and they were in a group that was basically fed ad lib, and then a group that had a reduced number of calories relative to the other group. And they found that the dogs that ate fewer calories and they stayed leaner, which is no surprise, but also lived longer, again, had lower incidence of arthritis and other diseases.
So let's transition over to exercise. Like you mentioned, kind of along the same lines, we know that exercise is important to the prevention of arthritis. So Dr. Frye, can you elaborate on the role of exercise in keeping our patients obviously lean, but also up and moving?
Yeah, of course. Exercise is one of the four fundamental things we like to focus on when treating osteoarthritis. So as Dr. Loftus noted, nutrition, weight management, joint supplements, and then exercise and pain management are the other two key components of medical management of this disease. Exercise-wise, we think about a few things. One is modification. So reducing high-impact activities or activities that exacerbate the disease, make the patients lamer. For example, we see so many patients that are running around after balls because they love fetching, but they can only do so much of that before they're holding a limb up potentially, or really sore after they get up from a long rest, something like that. And human medicine, we know that daily low impact exercise is key to increasing range of motion, function, actually reducing pain, okay, and improving lifespan and quality of life in people with suffering from osteoarthritis. So dogs are no different, really. And there are some studies examining low impact exercise and aquatic therapy. So that's water therapy. We have a lot of underwater treadmills for dogs around the country now because of this. And swimming is another option to think about. Other things for exercise are targeted physical therapies. So are rehabilitative exercises. So for example, a dog with hip dysplasia, we know there's some natural laxity, well, not natural, pathological laxity in the hip. And that can be ameliorated by engaging the active stabilizers. So those muscles that help stabilize that joint, we can strengthen them and focus on coordinating them to help maintain the hip in the socket, which will reduce progression of osteoarthritis theoretically, as well as help manage the discomfort associated with the disease and improve function. So exercises targeting the gluteal muscles or the adductors of the limb are really important. Sometimes we use sit to stands. It's simply a squat in human medicine, but in dogs, sit to stands help strengthen those muscle groups that you want, but they also don't overextend the hip, which can be painful in dogs with osteoarthritis of the hip. So that'd be one example. Another is dogs with elbow dysplasia and osteoarthritis of the elbows. Fairly common disease we see. They lose range of motion of the joint in flexion commonly. And then they have compensatory movements in order to adjust for that. So that might be overextending the shoulder or circumducting the shoulder and moving their weight or shifting their weight from their front to their back end. Those dogs have a very secure joint in the elbow, but because of the compensatory movements, we can see upstream injuries potentially and discomfort in those patients as well. So physical therapy would target range of motion of the elbows in that case. So exercises that help elbow flexion. One of my favorite ones is just simply a step over exercise where they step over an obstacle, or shaking hands. Lifting the paw up to shake hands will improve elbow flexion. The nice thing about activities that are encouraging the dog for natural movement versus passively stretching is the patients can choose a comfortable range of motion and engage those muscles themselves to help strengthen them. Whereas passive movements, you can overextend a joint, which could hurt them, and then they become resentful, and you're not getting that muscle engagement.
Something that I found so interesting about what you just said is, when we think of physical therapy, I think of getting a sports medicine and rehabilitation specialist involved in, this complicated plan that we have to formulate. But you're talking about step overs, you're talking about sit to stand, you're talking about shaking hands. I mean, these are pretty simple exercises that pet owners can do at home.
Yeah,
depends on the dog. I don't know that mine could do that, but
this is a solid point.
Yeah, that's might be true. We try to give them exercises. A huge component of what we do is at-home care, because they can come in twice a week, and we certainly see improvement with professional care, but they have to manage these patients at home, and they have to manage them in the long term. So devotion and commitment for lifelong management is important because osteoarthritis doesn't go away, and we know that. And having been in general practice as well myself, we see so many of these dogs and cats come in. Even changes like environmental modification can be huge. Many dogs and cats sleep on bed with us, but when they jump down, maybe arthritis in their elbows or wrists hurt, okay? So get them some steps or even just a bench or something that they can help reduce that impact coming down from the bed, or assist them into cars. You can get harnesses and ramps for that. So there's just so many options we can do at home with our clients to encourage compliance. You got to pick simple things. I try not to give too many exercises, environmental modifications, and then having them come back in the hospital when possible for professional assessment to see how they're improving and to readdress goals as things change. So hopefully we succeed in meeting certain goals, and then we can readdress the patient at a certain point, maybe 4 to 6 weeks out, and adjust those goals and adjust those exercises to match them to optimize our desires here with those patients for management.
So I appreciate all of the thoughts on prevention, because we know that that's so important when it comes to osteoarthritis. But what about these patients who are symptomatic? What are some of the principles we should really keep in mind when it comes to exercise if we suspect arthritis in our patient?
From an exercise standpoint, I like to assess patients' function, comfort. It's important to have a diagnosis. Sometimes in general practice, we have to make presumptive ones. And with osteoarthritis, that's fairly easy to do most times, especially if it's a significant disease or stage of the disease, I should say. But once we have that diagnosis and we assess the patient and we measure things like range of motion, you can use a goniometer for that. Muscle circumference or muscle strength. I actually prefer functional testing because it's more important and pertinent to what the patient does at home. For example, an owner might say, my dog really can't get into the car anymore, or has challenged ascending a flight of stairs to get into my home. So right away, I know that I need to work on the body parts that help that dog accomplish those tasks. So that could be core strength and hind limb strength when we're talking about ascending and maintaining a neutral spine, so you don't put too much pressure in certain joints. And then how long and what exercises will it take to meet those goals will dictate when I reassess that patient.
Any exam tips that you have as far as, make sure you don't skip checking this part, or, this is a really good way to rule out this type of pain? Any little tips and tricks that would be easy to pass on to general practitioners?
Yeah, I think when you're doing an orthopedic and neurologic exam or combined, often we have to combine them, to do it thoroughly and do it in sequence. So it's the same every time. I like the nose through the tail approach. I do gait analysis and movement first and posture assessment. And then I go into, okay, how does this patient feel standing for symmetry? How does this patient feel in recumbency for range of motion and discomfort and things like that? If there is a diagnosis like cranial cruciate ligament disease, very common, that can be managed very well surgically. And that'll reduce the progression of arthritis and it'll improve function in those patients. So some of these diseases are surgically managed, but they'll still get osteoarthritis, and you'll still have to consider medical management for those patients down the road as well.
Let's move back over to nutrition. What are some of the general principles that we want to keep in mind when we're managing a patient who has arthritis or one who might be predisposed to arthritis?
Mm-hmm. Well, let's start with predisposed. And that in many cases can, again, start in puppyhood. And we're particularly worried about large breed dogs and orthopedic issues, right? And so the nutrients of real concern there are calcium and phosphorus. So there's a lot of studies that looked at optimizing calcium and phosphorus in large breed puppies and how that impacted the incidence of orthopedic disease. The best thing to do is to find a good quality large breed puppy diet, because those have taken into account all of that research and have optimized those nutrients for orthopedic growth in our large breed puppies. So that's one of those things, again, starting really early and picking a good food. And then again, as they grow, the first thing that I think of in any patient is calories. So that's kind of the foundation, how much energy they're taking in. And so depending on what you need to do with diet, are you changing to a mobility diet, or are you changing them to a weight loss diet? Is it a combined weight loss mobility? What calories are you targeting? And if you have a patient that is in good body condition score, then generally what I do is estimate the calories that they're currently getting so that we can kind of, keep an even keel there. Everyone knows there are, the RER calculation, resting energy requirement, and then different factors that we can multiply by that to estimate what a dog's or cat's daily requirement is going to be. But those are really estimates. And if you have a kind of a proven number of calories for a patient that is optimizing body condition, then I would go with that. So that's kind of the first thing, is figuring out where your calories should be. Weight loss gets into another kind of category of energy calculations. If you don't know, then I think RER times 1.3 is probably, if, for most of our pets, our neutered pets, that's a pretty good starting point for an estimate. So that's the first place you're going to go. And then you want to think about what the diet is and what the characteristics are. So many of our patients with osteoarthritis, we're thinking about weight loss because that's a really integral component of their management. And so weight loss diets, the nutrients that we're thinking about are protein. We want diet that's high in protein because we're calorie restricting, and two things are happening. One, we're calorie restricting, so we want to make sure that they're getting enough protein, but also in the context of weight loss, we want to make sure that they're maintaining lean body mass and that they're really losing adiposity. So we want them to lose fat and we want them to maintain muscle. So having a lot of protein in the diet is helpful for that. The weight loss diets also have that concept in mind with other nutrients. So if you're calorie restricting and we're thinking about nutrients per energy basis, they're accounting for that. So they're making sure there are enough nutrients to meet their requirements, even though we're backing off on calories. Then you might have a mobility diet or maybe a combined diet. And those diets may have similar characteristics, often higher in protein. One of the main things that is key across the board is added omega-3 fatty acids. And it's probably worth mentioning here, we're talking about marine-based omega-3 fatty acids. I think there's sometimes the concept that all omega-3s are omega-3s. And so when you look at the label, this, veterinarians can look at the label or ask their clients to look at the ingredient list. If it's a diet they're unfamiliar with, you want to have fish oil or, some kind of fish source, maybe algae or something like that. If, it's kind of out there. If it's flaxseed or something like that, that's not going to give you the anti-inflammatory omega-3s or as anti-inflammatory. So be careful about flax, basically. So the vegetable terrestrial kind of based oils that are high in omega-3s aren't providing quite the right ones. So that's one thing to look out for on the label. The veterinary therapeutic diets for mobility know that, and their omega-3 profiles are pretty good. So omega-3s are kind of the top one I think about. And then, some of them have added nutraceuticals like glucosamine, chondroitin. So those might be in the diet themselves, or you might want to supplement them depending on the diet.
That's really interesting. I never knew that about the terrestrial sources of omega-3s. I always just kind of lump everything in and say
Yeah.
fish oil. So hopefully that's the right recommendation. I didn't even think of flax being a source of omega-3s.
Yeah, so flax is rich in the omega-3 alpha-linolenic acid. What you've probably seen EPA and DHA, that's eicosapentaenoic acid and docosahexaenoic acid. Those are the marine source, longer chain omega-3 fatty acids, and those are the ones that have more anti-inflammatory properties, developmental benefits, especially in neurodevelopment in puppies. So those are the ones you want to look for.
Interesting. And I have to ask, just because I get this question all the time in the exam room, what about owners who say, we're on krill oil and some of this other stuff?
So actually, krill oil, I like that. The problem is it's a little bit more expensive. But krill oil, interesting, is it's actually in the omega-3s are in phospholipid form. So they may actually be more bioavailable because they have higher water solubility, whereas most of the other oils are in triglyceride form.
So, of course, like we're talking about here, despite our best efforts, sometimes arthritis, we do everything we can to prevent it, but it's just inevitable in some of these guys. So one of the first things I reach for as part of my preventative strategy or in patients that are starting to develop symptoms are glucosamine, chondroitin, eggshell membrane type of supplements.
Yeah.
We just talked about fish oil. What does the literature say in respect to these supplements?
So if you look at joint supplements in general, we think omega-3 fatty acids, glucosamine, chondroitin, there's avocado, soybean, saponifiables, there's eggshell membrane, there's undenatured collagen. I might be missing some, but all of those have some subjective evidence for benefit. So there's literature out there that shows that they improve owner perceptions of lameness and things like that. So that's true for essentially all of them. When you get into the more objective outcomes, the supplements that have the higher levels of evidence are your omega-3s, and those actually not just have more evidence at that higher level, but also kind of more studies. So there's a lot of robust evidence for the benefit of omega-3s in osteoarthritis. Avocado, soybean unsaponifiables, and undenatured collagen also have some of that. There's some positive outcomes that are objective outcomes or quantifiable outcomes. So if you look across the board, number one, I would put omega-3s. I would say you want to put those in the diet. And then the other ones kind of fall below that. And if I had to pick out some, just based on the evidence we have now, the avocado, soybean, unsaponifiables, and undenatured collagen would probably rise up. But glucosamine, chondroitin, again, there's some benefit for that. It's really common. It's in a lot of joint supplements. So I think that's still reasonable to supplement for a lot of these patients. Dosing on many of the products is actually a little bit lower than what you might need for optimal anti-inflammatory effects in osteoarthritis. So I would say you want to target more like 100 milligrams to 300 milligrams per kilogram a day for marine-based omega-3 supplementation. And you also have to keep in mind what's in the diet. So if you have a mobility diet that's really high in omega-3s, you may not need to supplement any additional omega-3s. So it's looking at the total intake overall.
I love that. I always feel like I'm Oprah when it comes to fish oil. You get fish oil and you get fish oil. Everybody gets fish oil.
Yeah, no, I should take fish oil, but
Yeah, I have that question myself where I put all my patients on fish oil. Why don't I take it?
Yeah, I'm just too lazy, I think, is the honest answer.
I can relate to that. So let's talk about comorbidities for a second. A lot of these patients, they are older and we're dealing with different comorbidities in addition to their arthritis. So what are some of these common conditions we might encounter and what types of things should we keep in mind when addressing them?
Yeah, so I think, boy, there could be a lot, you're asking an internist, so that's a dangerous question almost. It could be anything, but, patients with osteoarthritis are generally older, right? So we think of the age-related diseases that we see more commonly. So kidney disease is certainly up there. Endocrine diseases, and so on. And so it really depends on what the comorbidity is and how we need to manage that. So, for example, if you have a patient with significant renal disease, that is going to limit what we can do therapeutically, potentially, especially from the standpoint of non-steroidal anti-inflammatory management. So then you have to get creative with pain management, and I think those are cases where Dr. Frye or other rehab specialists would be really beneficial in coming up with a comprehensive plan to manage them as best you can without the benefit of an NSAID. In older patients, we often see either cachexia or sarcopenia. What's the difference? Cachexia is a loss of lean body mass associated with the disease. Sarcopenia is seemingly age-related. So there's no disease, but there is a loss of lean body mass. So when we're encountered with those situations, we want to target a diet that's going to really maintain lean body mass. Can we mitigate some of the disease that's driving their sarcopenia? And our exercise is going to help to maintain that lean body mass. So again, it's kind of a multimodal approach. We want to maintain their mobility. We want to give them an amount of dietary protein that is as high as appropriate for that individual. So another thing that goes along with that is this. Maybe it's the concept has gone by now, but for a while there was the concept that you want to back off on protein for your geriatric patients. And I think a lot of that was a concern for renal disease. But if they don't have renal disease, being on a high protein diet is not going to cause renal disease. So don't worry about protein if they don't have renal disease, is kind of the short. And make sure they have optimal protein. So you want a geriatric diet that doesn't take the approach of lowering protein. You want the opposite. You want to bump up their protein with age. And that's going to help mitigate sarcopenia and cachexia. So
I've heard that more and more that, like you said, this concept that we used to have of restricting protein, maybe we weren't on the right track there. And actually, we want to make sure we're maintaining a little bit higher level of proteins in our older patients.
Mm-hmm. Yeah, for sure.
Dr. Frye, do you want to jump in here for a minute and talk about your approach to managing sarcopenia and cachexia in these geriatric patients from a sports medicine and rehab perspective?
Yeah, so I think, sure. I mean, once they're on an optimal diet, and I often, if they do have comorbidities, I need a nutritionist to help me with that. That is something that's very complex to balance, I believe. But once they're on that kind of optimal nutrient profile, exercise plays a key role in helping to maintain muscle mass. We know in human medicine that strength training and conditioning programs are essential for that. I believe they are in animal medicine. I see results from it. We don't have the scientific data to support that yet. The other thing to think about in these geriatric dogs and dogs suffering from comorbidities with age is function. Can we kind of establish what normal function is per age and breed over time? It's going to take a lot of work, and then be able to establish programs to match that or meet that and then optimize outcomes.
It sounds like there's a lot of opportunity out there for learning more about managing these conditions from a nutritional standpoint and from a physical therapy type of standpoint.
Yeah, and I think the other thing to add here, and I think John hit up on it, is a lot of these patients can't or they don't tolerate traditional pain management, which, the biggest one would be the non-steroidal anti-inflammatory drugs. And they need something more comprehensive. And some of it can be done in general practice. There's other oral medications. They don't seem to have as robust support in the literature or even in the clinical setting. For example, gabapentin, pregabalin, things like that. Tramadol certainly has lost support over the years for good reason, probably. And so then we're thinking about interventional pain management options, which we do here frequently. That could include, targeted joint injection therapies with regenerative medicine like platelet-rich plasma or stem cell therapy. We'll even use cortisone injections occasionally, and Dr. Loftus is going to judge me here, but if it's for a short time period for a patient to, say, lose weight, or some of these other important nutritional interventions and exercise interventions to get us through that 6 to 8 weeks, we can find that they do much better for that 6 to 8 weeks, and they tolerate their exercise program better. And then when that single intervention has subsided, and we have achieved our weight loss and we've achieved some strengthening, we find that they may not need any more of those interventions.
I was just going to add, I was thinking when you were talking about, maintaining these exercise programs through life, the proof is kind of in the pudding with the two of us, because remember, there was a time in vet school when I beat you at a push-up contest.
What?
Yeah.
I don't remember this.
I love this conversation. I'm so interested.
I'm probably suffering from cognitive dysfunction, John. I might need some of those other oils. The others recommend.
What oils are you talking about, Dr. Frye?
Please elaborate. Be more specific.
The edible ones, of course.
Oh, okay.
Oh, I love this conversation. The subject matter, I'm sure you can tell I'm having to hold myself back from keeping us here for 5 hours, but also the company is fantastic and it's so much fun.
Likewise.
So we're talking about so many things here, different supplements, exercise regimens, managing comorbidities. There's a lot to it. So of course, that brings up the subject of client communication and how are we going to get our message across in a way that doesn't overwhelm our clients. So what are some of the key points that you guys make sure to discuss with these clients when we're talking about managing these patients?
From the nutritional standpoint, I think client communication really starts with recognition and getting a really good history. And I think this is where, because it's a two-way street, right? And I think there are many cases where the nutritional history for a patient is lower down on the totem pole. And I, out in busy general practices, you're not going to dive in that deep into nutrition, but I think these are the kind of cases where you have to do that. And one of the ways that I think achieving that is a lot more sustainable and easy is to look for nutritional history questionnaires or whatever, and they're online. The different American Academy of Veterinary Nutritionists, their websites, the Nutrition College, which is now with the ACVIM, they might have it up now. They're kind of in transition with their website, but WSAVA has them. If you just Google nutrition questionnaire dog or cat, something will pop up. But having those tools in your practice can really alleviate some of the time you spend. The other thing is, so you give the patient the form to fill out, then have your technician or a receptionist or someone else go through that, and then you go through that as the veterinarian again. I can't tell you how many times when I was a nutrition resident, we'd have cases that would come in, they'd talk to a student and they'd get this nutrition history. Then they talk to the resident on, say, neurology, they'd get this nutrition history. Then I'd come in and go over the nutrition, and you'd get this history. So by the time you're done, they're eating like 75 different things, and 3 times as many calories as the student got. So part of it is really wearing them down, honestly. And then I think being really empathetic and coming up with reasonable goals is super important, because a client is not going to be successful in a weight management protocol, for example, if you come up with one that they're just not going to do, that's doesn't fit their lifestyle. And so having that back and forth and really making sure, is this something that you can do? If not, well, let's come up with another approach.
I like what you said about making sure that we're formulating a realistic plan. It makes me think of something that I tell owners. Usually it's when we're talking about medicating a cat and they'll ask me about different medications. And I always tell them the most effective medication is the one that makes it into the cat.
Mm-hmm.
So the most effective nutrition and weight loss program is the one that they're actually going to do.
Yep, absolutely.
Dr. Frye, what do you think as far as client communication?
Well, I'm even lazier than John. I like to ask them what they want. I say, hey, why are you here? What are your goals today? And I see if I can match them with my own. But that often helps me with compliance and buy-in. And because it's a long-term, lifelong disease, you really need to achieve that. And then the other recommendation I have, which I'm sure all veterinarians know by now, is to set expectations. Because if you don't, and John alluded to this, but if you don't set expectations that are reasonable, people get disheartened. And so I really like to recheck my patients from a physical therapy standpoint at least every 4 to 6 weeks, at least during the initial beginning of a program. And then once I know we have buy-in, we have compliance, we're attaining reasonable goals, then management is lifelong, and I deliver that and put that back in the hands of the families. And then I say that these are things I can offer here, in the clinic or in the hospital, whether it's pain management options and things like that. And these are things you can do at home, and it's a team effort. So that's how I try to approach it.
Guys, I kind of want to revisit the push-up contest and redo it here and now and see who wins.
Yeah, well, we're both a little older. Actually, I suffer from some osteoarthritis. I don't know about you, John, but I might, yeah.
All right.
I don't know if it's osteoarthritis or just a complete failure of my body.
I can relate to both of those things, so I'll let you off the hook and we'll stay away from the push-up contest for today. But this has been so much fun. I would really love to go down the different rabbit holes and ask you more about what you do for these patients and the different resources that are out there and available. But for the sake of time, I will hold back and go ahead and wrap it up. Thank you guys again so much for joining me today. You guys are a wealth of information, and it's been fantastic.
It's a pleasure.
And thank you to Blue Buffalo for sponsoring this edition of Vet2Vet. Check out the Spark section of vetfolio.com for more of our V2V discussions on various topics in veterinary medicine. And remember, if one animal is better off because of you today, it's a great day.